Welcome, Amanda.
Thanks. Can everyone see my slides? Yeah, all right. I will get going. Hang on one second. All right. So as Joanna said, I'm an assistant professor in the Department of Psychological and Brain Sciences at the University of Iowa. I'm a licensed clinical psychologist, and here at Iowa, I direct a lab called the Mechanisms of Adult and Youth Psychopathology Lab, or MAPLE. And I also co-direct a new program that's just launching right now as we speak with Dr. Bengi Baran. This is the Psychosis Risk Intervention Education and Research Program, or PEER. In terms of how I got started in psychosis research, I would say really it was early mentorship that really drew me into this area. So I had a really wonderful mentor just as I was wrapping up my undergraduate studies at the University of Toronto. Jean Addington was directing an early psychosis research program at the Center for Addiction and Mental Health that also included a clinical high risk program as well. So I've received really excellent training and mentorship from her and just really fell in love with this area of research. I then went on to complete my graduate training in Ohio at Kent State University, and my program there was focused on serious mental illness. And then my internship and postdoc brought me out to UCLA, where I worked with the early psychosis treatment team for many years prior to coming to Iowa. In terms of disclosure, so I've received research funding from the Canadian Institutes of Health Research, NIMH, the Brain and Behavior Research Foundation, Alkermes, and the American Psychological Foundation. I've also received payment for clinical assessment services from Metavante Prophase. So in terms of the aims for this Lunch and Learn, I wanted to provide a very broad overview of early detection and intervention strategies for psychotic illness. We'll talk a little bit about psychosis and psychotic illness, briefly cover what we've learned so far about the illness course and why early intervention is important. I'll talk about a treatment model that's been implemented in the United States, as well as barriers to recovery. I'll also talk about another strategy, which involves intervening before illness onset. And then I'll talk about our new program for Iowa that we're launching now. So when we talk about psychosis and psychotic episodes, we're referring to psychotic symptoms that reflect distortions in perception, and that includes hallucinations, distortions in thought content, like delusions, and disorganized communication and behaviors. So these are the features that typically come to mind. But in addition to these dramatic symptoms, we also see disruption in the expression of emotions, as well as the experience of pleasure and the person's internal sense of motivation and drive to engage in activities. So these are referred to as negative symptoms. And then finally, we also see functional impairment across multiple domains. So this includes occupational or academic functioning, social relationships, and independent living. Psychotic symptoms can occur in the context of a number of medical and psychiatric disorders, including encephalitis and dementia and severe mood disorders, as well as primary psychotic illnesses like schizophrenia. And these primary psychotic illnesses will be the focus of the talk today. So in schizophrenia, what we tend to see are episodes of psychotic symptoms. So that's indicated here. Let me get my laser pointer here in the green line, where symptoms will wax and wane in terms of their severity. However, it's important to note that there are a lot of individual differences regarding the degree of remission or relief that people will experience between episodes. Some individuals will have pretty minimal psychotic symptoms between episodes, and others will have subthreshold or milder versions of symptoms between episodes. And still others will have symptoms that tend to be pretty continuous. In contrast, negative symptoms, so indicated here in this sort of reddish orange line, and cognitive impairments in the blue line tend to have a more stable course over time, and these symptoms can be quite disabling. A number of research groups, including Nancy Andreasen's group here at the University of Iowa, conducted studies where individuals who were recently diagnosed with schizophrenia were followed over many years. And this was in an effort to better understand the course of the illness. So these longitudinal studies, along with studies of the genetics of schizophrenia, neuroimaging studies, behavioral studies, family studies of unaffected relatives, and intervention studies, have led to a reconceptualization of schizophrenia. So in the last 2 to 3 decades, there's been an increasing recognition of the cognitive impact of schizophrenia, leading to the reconceptualization of schizophrenia as a cognitive disorder. A second shift in the field is the reconceptualization of schizophrenia as a neurodevelopmental disorder. So previously, schizophrenia was thought of as a progressive neurodegenerative disorder, similar to something like Alzheimer's dementia, but with an early onset. A third major shift in the field was the emergence of the recovery model in the 1990s, and this served to broaden treatment to include individualized goals and improving quality of life, as opposed to an exclusive focus on managing psychotic symptoms. So as I mentioned a moment ago, in the last couple of decades, there's been increasing recognition of the cognitive impact of schizophrenia. And although it isn't included in the DSM criteria for the disorder, impaired cognition is a core feature of schizophrenia, and it's also quite common. So cognitive impairments impact an estimated 80% of the people who have the diagnosis. Even when cognitive performance falls within normal limits or better, it's been argued that individuals with schizophrenia will still perform at levels that fall below expectations. And evidence for this notion come from studies of twins who are discordant for schizophrenia, from studies comparing actual to expected performance based on a person's level of intellectual functioning prior to the onset of their illness, and from studies of people who have a diagnosis of schizophrenia and also have intellectual abilities in the superior range. So to illustrate what I mean by cognitive impairment, in this figure here, I have different cognitive domains plotted along the x-axis, ranging from speed of processing, attention, working memory, visual and verbal learning, reasoning and problem solving, social cognition, and then an overall composite score. I've set the performance of a sample of adults without mental illness to the 0 line here. And we would refer to this as our normative sample. So as a group, individuals with chronic phase schizophrenia are plotted in black here. They typically perform about 1 to 2 standard deviations below the normative sample across a variety of cognitive domains. I've also plotted this profile of a large sample of individuals with recent onset schizophrenia. So these are folks who have been diagnosed within the last 2 years. They're plotted in yellow. And as you can see here, their profile is pretty similar to what we would observe for folks with established illness. So this tells us that impaired cognition is already evident at the start of the illness. So in summary, the performance pattern that we tend to see in people with schizophrenia is a diffuse pattern that impacts a variety of cognitive domains, ranging from lower order perceptual processing up through higher order executive functions. And these impairments are present early in the illness course. Comprehensive quantitative reviews that synthesize findings across a number of studies report large effect sizes across domains. Notably, these cognitive performance impairments don't appear to be substantially impacted by clinical factors like severity of psychotic symptoms or duration of illness, nor does it seem to be attributable to the effect of medications. And so I say this because cognitive impairment is consistently reported in people who are not taking any antipsychotic medications at the time of the cognitive testing. And we also see these impairments among people who have never taken antipsychotic medications during their illness. The relationship between cognition and functioning in the community is also well established in the literature. And the strength of the association ranges from small to medium for individual cognitive domains and becomes stronger when we look at overall composite scores. This is a pretty robust finding. It's a finding that's been replicated by research groups around the globe using a variety of cognitive tests with a diverse range of participant samples. This relationship between cognition and functioning is apparent early in the illness course and even among those who are at risk for schizophrenia. And longitudinal studies demonstrate that the relationship holds up over time. So cognitive impairment will predict later community functioning over follow-up periods ranging from 6 months to 4 years. So taken together, all of this work suggests that cognition is a potential treatment target that may improve functional recovery in people with schizophrenia. So one thing that I want to point out here is that I've been speaking very broadly about group differences. So I'm comparing the average performance of a group of people with schizophrenia to the average performance of a group of people without schizophrenia. But it's really important to note there's a lot of variability in performance among members of each group. And so what we see is that portions of the distributions of cognitive scores for each group will overlap with each other. So this means that there's people in each group who will exhibit high or low cognitive performance, but the group averages, which are represented here by the lines running down the center of the distributions, are different from each other. So this leads us to the next major shift in the field, reframing schizophrenia as a neurodevelopmental disorder. So as we all know, this is an illness that is typically diagnosed in late adolescence or early adulthood at the onset of frank psychosis. And so these types of symptoms are what captures clinical attention and necessitate an intervention. However, oftentimes there are early warning signs of psychosis that emerged in the months or years preceding frank psychosis. And we also know that there are very subtle disturbances that are present early in childhood with respect to cognitive development, motor development, and social development. These subtle changes occur many, many years before there's any hint of psychosis. And so what this suggests is that the processes that are associated with schizophrenia start pretty early on in life, and then they unfold across development. So the next big shift in our thinking is related to the growing influence of the recovery model for psychosis and the implications for treatment. For a long time, there was a prevailing and erroneous notion that people with severe mental illness wouldn't benefit from psychosocial interventions like psychotherapy. And treatments were generally focused on pharmacotherapy and medication management of psychotic symptoms and striving for clinical remission. The recovery model took hold in the 1990s, and it widened the focus to include the individual's goals and their values. So in other words, what's important to this individual? What roles provide them with meaning? And what kind of a life do they want to live? What this means is that the individual client becomes an active participant in their treatment. They're part of a collaborative team, and they contribute to treatment planning and goal setting. And this model lends itself really well to psychosocial interventions that are geared towards skill development that will facilitate the client moving towards their goals regarding work and school, their interpersonal relationships, and their integration into their community, goals surrounding independence and well-being and quality of life. And the recovery-oriented approaches also support engagement in activities that is enriching to the individual. And the recovery model is central to early intervention treatment programs. So why is early intervention for psychosis important? On this slide here, I just have sort of a very sort of simplified cartoon of functional trajectories. So here in yellow, we have sort of a typical developmental trajectory of an adult who does not develop psychosis. In blue, we have an individual who is experiencing early warning signs. Their functioning declines in the first episode of psychosis. There's some degree of recovery and then long-term stability. The idea with early intervention is that we want to alter that trajectory and enhance recovery. So that's this red line here. The aim is to reduce disability and also to reduce the likelihood of future psychiatric crises. And we know that early intervention programs are associated with better outcomes compared to treatment as usual. So here I have cited a meta-analysis. This was combining the results of 10 studies with over 2,000 patient participants. And what they found was that early intervention programs had better outcomes, including the clients were less likely to discontinue treatment early. There was a lower risk of psychiatric hospitalization, a lower relapse rate, improvement in symptoms, and I think most importantly, better functioning and better quality of life. So you may ask which types of treatments or which components are effective. So here on this slide, I have a list of different components. It's definitely not exhaustive, and I've included a link here at the bottom for anyone who's interested and wants to take a look. It leads to the American Psychological Association's Division 12 page, which reviews the empirical support for various types of interventions. But sort of hitting the highlights here, we know that pharmacotherapy can be very effective for managing psychotic symptoms. In early course psychosis, the sort of rule of thumb is to start low, go slow. So start with the lowest effective dose and titrate up slowly. We also see an increasing use of long-acting injectable forms of the medication. This has been demonstrated to be really helpful to prevent relapses, and there's also some evidence accumulating that these long-acting injectables may have a neuroprotective effect. We also know that psychoeducation and illness management is effective, and this is individualized and really framed within the recovery model. So, having clients identify what are my early warning signs of a relapse? What's my action plan? Who's part of my support network? What factors contribute to my well-being? And a lot of this involves having clients get in touch with their values and identifying behaviors and attitudes that are consistent with their values. We also know that family interventions are effective. The focus here is on improving communication and relationships between family members, maintaining boundaries, and also supporting recovery. As we also know, that first episode of psychosis is a major crisis for the entire family, not just for the individual who's suffering with symptoms. And so a big portion of family work in early intervention programs surrounds managing that crisis. There's also a great evidence base for supported work and education programs. An example here is an intervention called individualized placement and support. In that program, the client is paired with a specialized team member who will assist the client with job searches for competitive employment. The team member will provide support and help prepare the client for interviews. They can also help interface with the supervisor and support job retention. Finally, they can also assist the client navigate through sort of tricky situations on the job. So things like negotiating appropriate work accommodations so that they can attend treatment, things like that. We also have good evidence for the effectiveness of cognitive behavioral interventions. So two that have received empirical support are cognitive behavioral social skills training, and this is an intervention that's been adopted by the Veteran Affairs for treatment of psychosis. There's also good evidence for the effectiveness of CBT for psychosis, and there's emerging evidence to support the use of acceptance and commitment therapy and motivational interviewing. And then finally, cognitive rehabilitation. This involves repeated practice of cognitive tasks geared towards improving cognitive skills like attention and perceptual discrimination thresholds, working memory, problem solving, and so on. These programs might be computerized, or they might use paper and pencil tasks, and they may be administered individually or in groups. Typically, we also include what's called a bridging component. This involves a discussion of how to link the skills that the client has learned in the cognitive training lab to their everyday life. So several of these components were combined together and tested in a large multi-site study by NIMH called the RAISE study. So RAISE stands for Recovery After an Initial Schizophrenia Episode. The program is an intensive wraparound program with a team of specialists, and the interventions are designed to be developmentally appropriate for adolescence or early adulthood. The treatment program lasts for about 2 years, and then after which the clients are transitioned out to receive mental health care in their community. So the RAISE study investigated the effectiveness of coordinated specialty care for early psychosis and also the best practices for implementing such a program in community mental health centers. So this was a team-based approach. It included a number of the interventions that I mentioned on the last slide. So psychoeducation, psychotherapy, pharmacotherapy, there was family interventions, case management, and supported work and education. And what they found was that 2-year follow-up, compared to treatment as usual, coordinated specialty care interventions yielded improvements in symptoms, functioning, and quality of life. Again, this was in comparison to treatment as usual in the community. What they noted as well was that the impact was larger when treatment was initiated early. So I was really happy to see when I was planning to come to Iowa that there's 2 CSE programs currently running in Iowa. One is up in Cedar Rapids called the FIRST program, and the second is the Restore program at Irely Ball in Des Moines. And I'm not sure if anybody has sort of an inside scoop of whether any additional programs are coming down the pipeline, but I would be interested to hear during the Q&A. So as I mentioned a moment ago, the coordinated specialty care treatment was most effective when treatment was delivered early. Treatment delays represent a barrier for recovery. In terms of what we refer to this as in the literature, we call these treatment delays the duration of untreated psychosis. So the length of time from when the person first starts experiencing psychotic symptoms up until they receive adequate treatment for the psychotic symptoms. And the estimate from RAISE for the average duration of untreated psychosis in the community in the United States is 74 weeks, so almost a year and a half. This seems like it would be a pretty good estimate for the community pretty broadly across the US. This study included 404 individual clients from, I think it was like over 30 sites across 21 states, and the sites included in RAISE were community mental health centers. So this seems to be a pretty good representation of what we would expect generally. I don't have an updated estimate for the current duration of untreated psychosis in Iowa, but Bengi and I found this paper a little while back. This is from Nancy Andreasen's group. It was published in 2003 from the Iowa longitudinal study, and the average duration of untreated psychosis in that sample was also 74 weeks. So duration of untreated psychosis matters. This is a big deal. Here I'm going to orient you to the figure here. So what I have plotted here are effect sizes from an aggregation of studies. So here we have various outcomes, negative symptoms, positive symptoms, global symptoms, various domains of functioning, quality of life, cognition, hospitalizations, and so on. And the way to interpret this is the 0 line indicates no significant effect. If effect sizes fall on this side of 0, it means that longer duration of untreated psychosis is associated with a better outcome. On this side of the line, a longer duration of untreated psychosis is associated with a poorer outcome. And so this meta-analysis combined results from 129 studies with over 25,000 individual patients. What they found in general was a longer duration of untreated psychosis was associated with a variety of poor outcomes compared to shorter DUP. And a longer DUP is associated with a need for more protracted treatment and incomplete remission. So what contributes to duration of untreated psychosis? One factor that contributes is awareness of psychotic symptoms, early warning signs, and treatment options that are available in the community. And this is at the level of the individual who is experiencing the symptoms, at the level of the family and friends who the person may turn to for help or who may be noticing that something's going on with their loved one. And then also professionals who may encounter these individuals experiencing symptoms along their pathway to care. So this would include, general practitioners, school nurses, teachers, private practice clinicians, and so on. And what we know is that information campaigns can actually reduce the duration of untreated psychosis. This information comes from a series of really interesting studies that were conducted in Norway, where the researchers directed information campaigns both to professionals who are along the pathway to care, so GPs, nurses, and so on. They also put together an information campaign for the general public, providing information about what the early warning signs of psychosis looks like and where to get help. And they put, ads in newspapers, on the radio. They had ads running at the beginning of movies at the movie theaters and so on. And what they found was a significant reduction in DUP in the region that had the information campaign compared to a similar region that did not have the campaign. So here in Norway, at that point in time, the average duration of untreated psychosis was about 16 weeks. And the region with the information campaign, it was reduced down to 5 weeks. And notably, in a subsequent study, they noted that the reduction in DUP went away when the information campaign went away. So when the information campaign was discontinued, the duration of untreated psychosis went back up to 16 weeks. And this was despite the availability of early psychosis treatment programs in the region. So it's not enough just to have these programs available. People need to know about them, and they need to be aware of what the early warning signs of psychosis are. We also know that there is a very complicated pathway to mental health care, and that the type of the outcome of those contacts makes a big difference for duration of untreated psychosis. So individuals and their families oftentimes will make several attempts to get help before they receive a successful referral to adequate treatment. And just off the top of my head, I think a recent estimate from a study was about a median of 5 contacts. We also know that oftentimes when someone is experiencing psychosis, it quickly becomes a psychiatric emergency, which may lead to interactions with law enforcement and emergency services. And unfortunately, sometimes the way that individuals will get into treatment is through this route. It would be much better if we could get people into treatment before there's a psychiatric emergency. And then finally, another barrier is the availability of mental health services in the community. So there's a limited number of providers and long wait times for services. So I've been talking about these, early psychosis, early intervention programs, and a question that comes up is early intervention early enough? And is it sort of a misnomer to call these early intervention programs? It seems like at best it would be on-time intervention. Really, early intervention would be intervening before the onset of illness, so during what is typically referred to as a prodromal phase. So what do prodromal symptoms look like? Many look like milder versions of psychotic symptoms. So, attenuated positive symptoms includes perceptual aberration. So things sound different, look different, feel different, taste different, as opposed to a full-blown hallucination. It may involve having unusual thoughts or magical thinking or overvalued ideas or suspiciousness, as opposed to a full delusion that is fixed and impairing and influencing one's behavior. We also see negative symptoms during the prodromal phase that look very similar to what we see in individuals with established psychotic illness. So this can include low motivation and drive, a diminished expression of emotion, and social withdrawal. We will also occasionally see disorganized symptoms, not to the level of what we would see in an individual with a psychotic illness. They'll be attenuated somewhat. So this can include vague or odd speech, circumstantial speech. The person may report that they're having a hard time organizing their thoughts, and some oddities of their behaviors. We also see symptoms that are less specific to psychosis, so general symptoms. So things like sleep disturbance, changes in mood, changes in cognition, irritability, things like that. And then finally, we would see a decline in functioning. And so this would usually be sort of evident in terms of work or school performance, having a hard time maintaining interpersonal relationships, and decline in self-care and hygiene. So can we predict who will develop psychosis? Here we need to think about balancing the sensitivity and the specificity of our assessments and measurements. So sensitivity refers to the true positive rate, and here a higher number is better. So an example that I think we're all intimately familiar with is COVID testing at this point. So an example here would be your COVID test is positive and you actually have COVID. So that would be a true positive. And if our sensitivity is too low, it means that we're missing lots of cases. The specificity refers to the true negative rate. And again, higher is better. Going back to our COVID example, if our COVID test is negative and we do not have COVID, that would be a true negative. If our specificity is too low, that means that we have lots of false positives. And really with our assessments, we're trying to sort of balance these two, and there's always going to be a trade-off between sensitivity and specificity. An empirically based risk calculator that's been developed using measures that can be readily obtained in a clinic. So this risk calculator does not include any like neuroimaging or EEG or blood biomarkers. What it includes is like demographic factors, a family history of psychosis, severity of selected attenuated positive symptoms, cognitive performance, social functioning, and the presence of certain types of stressors and trauma. And this risk calculator in an independent sample had a sensitivity of about 91% and a specificity of about 37%. So what this means is that about 91% of individuals who were at risk were correctly classified, but only about 37% of those who were not at risk were correctly classified. So this means that we're very good at detecting individuals who are at risk, but there were false positives. And we need to think about what are the potential consequences of a false positive for the individual and for their family in terms of stress and stigma associated with the potential for serious mental illness. And so our goal is to improve these prediction models through research. So can we predict among those who have been identified as being at risk, can we predict who will develop psychosis? So across multiple studies, there is about a 30% conversion rate at 2 years. So what this means is of the pool of individuals who have been identified as being at risk for psychosis, at 2-year follow-up, about 30% have developed a psychotic illness. So you may ask, what's going on with the other 70%, or sometimes referred to as non-converters in the literature? And the outcomes there are pretty variable. So some individuals will not develop a psychotic illness, but instead will have long-standing and relatively stable psychotic-like experiences. So they continue to have those attenuated symptoms, but they never reach the level of full psychosis. Another subset of individuals will recover, or their symptoms will remit completely. And then another subset of individuals will develop other forms of psychopathology. So they may develop mood disorders or anxiety disorders, things like that. I think it's actually really important for us to study these non-converters in addition to people who develop psychosis, because they may be able to tell us a little bit about what factors may protect against development of psychosis and could potentially inform our prediction models and interventions. In terms of the predictors of conversion among individuals who are at risk, cognitive performance has a good evidence base for predicting conversion to psychosis. Poor functioning, especially in the social domain, and the presence of certain types of environmental stressors, including bullying, trauma, and early cannabis use. Other candidate predictors that are being evaluated include dynamic models that take into account changes in symptoms and functioning over time. So not just using that one value at the initial assessment, but looking at how things develop over time to predict conversion. Neurodevelopmental changes in brain structure and function and coordination between regions. There are also some candidate electrophysiological markers from EEG, genetic markers, inflammatory markers, and neuroendocrine markers. So here I just want to address sort of a change in nomenclature in the field. So originally, individuals who were identified as being at risk for psychosis were the term was prodromal was used to sort of reflect that we're catching individuals who are in that early phase immediately prior to the onset of psychosis. However, prodrome is a retrospective concept. This is, an individual has to develop a disease in order to have a prodromal phase. But we know that the vast majority of individuals who were identified as being at risk or being identified as being prodromal don't actually go on to develop psychotic illness. So clinical high risk is the preferred term to describe this at-risk mental state. And I think this term adequately captures the sort of prodromal nature of the symptoms that we're assessing for that precede the onset of psychosis, but it also acknowledges the limitations of our prediction methods. So how do we assess for clinical high risk? So there are a variety of methods that have been established, and there's a consensus among programs for various methods. There are self-report screening questionnaires. So a commonly used questionnaire is called the Prodromal Questionnaire Brief, or PQB. There are semi-structured clinical interviews, and the main assessment that's used here in the US is the structured interview for psychosis risk syndromes, or the SITS. And then there are cognitive tests that tap into working memory and verbal learning that's been identified as risk factors for conversion. So in terms of the sort of historical perspective and development of programs specifically geared towards individuals who may be at risk for psychosis, the very first clinical high-risk program called the PACE Clinic was established by Pat McCleery and Alison Young at Origin Youth Mental Health in Melbourne in 1995. The PACE program was an offshoot of their existing first episode psychosis program. And the treatments were developmentally informed, and there was a focus on functional recovery. And they were able to offer pretty comprehensive services through the clinic, including case management, psychiatry services, family groups. They offered academic and occupational support services, and referrals and community liaison services. This early program, they were keenly aware of stigma associated with severe mental illness. And so as a result, they purposely moved this service away from an acute care setting and put the clinic in the community. In the late 1990s and early 2000s, clinical high-risk programs started popping up around the world. In the mid-2000s, NAPLES, or the North American Prodrome Longitudinal Study, emerged. This was a North American consortium. So these were individual CHR clinics that decided to join forces and pool their data. So they wanted to combine their efforts to identify predictors of conversion. And a key product of that consortium was the development of that risk calculator that I mentioned a moment ago. In 2020, a large international consortium was created called ProNet. The aim here was to build upon what was learned in Naples with an eye on predicting individual trajectories and informing personalized medicine. We think about common elements of these programs. So there's been a convergence on criteria for clinical high-risk syndrome and the assessments that are used to establish risk status. These programs offer a free risk assessment to clients. They offer consultation and referral and longitudinal monitoring of symptoms over time. Some of these programs also offer treatment groups, supported employment and education, case management, psychiatry and medication management, and some also have first episode psychosis services integrated into the program. So these programs have been popping up around the world and throughout the US. To the best of my knowledge, the closest CHR clinic to us is the Early Psychosis Network up in Chicago that's led by Drs. Christine Hooker and Vijay Mittal. So this leads to a program that Dr. Baran and I have been developing for Iowa. So PEER, which stands for Psychosis Risk Intervention, Education, and Research. And this is our CHR program for Iowa. So the PEER program is housed at Seashore Clinic in Stewart Hall, which is the photo up above, and in our labs at the Psychological and Brain Sciences building at the University of Iowa. So our program is out in the community, not in the hospital. We offer a psychosis risk assessment. So this is a research assessment that is provided at no cost to the client or their family. In terms of what the client can expect, we will gather information about their psychological and social history. We administer gold standard measures of symptoms and cognitive performance. We also collect collateral information. So oftentimes, with adolescents and young adults, families are quite involved in treatment. And so they may accompany the individual to their appointment. And so we have an opportunity to interview the parent, to gather information about developmental history and the parent's assessment of the client's functioning. And we can also request medical records as well. We'll provide feedback to the individual, and if they choose to include their family, the family can be part of that as well. So the feedback involves interpretation of the assessment data and providing feedback regarding the individual's potential risk for psychosis. We'll make recommendations and referrals based on the assessment data, and we'll also provide education about modifiable risk factors. So things like sleep, stress management, cannabis use, things like that. And for individuals who meet CHR criteria, we are able to offer a longitudinal monitoring study. And so what this involves is having the individual come back and meet with us every few months, and we can check in to see how things are going in terms of their symptoms, functioning, cognition, and a whole host of other factors. We can also offer participation in other studies. In terms of the procedure for sort of identifying individuals and referring them to our program, what we envision is that we'll be able to provide education and outreach to professionals in the community who may encounter these young people who are at risk for psychosis, and they can use sort of brief screening questionnaires to assess for the presence of psychotic-like experiences. So these brief screeners may be administered through schools or clinics. We'll have a version on our program website and so on. If an individual is interested in receiving a risk assessment, they can contact us and we would conduct a telephone screening, which would include a longer screening assessing psychotic-like experiences, family history of psychosis, and functional decline. If it appears that the individual is having psychotic-like experiences or they have a family history of psychosis, we would invite them in for a risk assessment. And so this would be the peer program interview. And then for individuals who meet criteria, we would offer continued monitoring through our longitudinal study. So in terms of the potential benefits of longitudinal monitoring, so this is a pretty, we're not sort of doing any interventions, or really we're just meeting with people over time until they no longer want to meet with us. So we're happy to follow people for years if they're willing to. So if we think about the potential benefits for the individual, for the 30% of individuals who are identified as being at risk who do go on to develop psychosis, longitudinal monitoring means that we are able to catch psychosis early. So, the upper limit for duration of untreated psychosis would be, the duration between their visits at the clinic, which would be a couple of months. The family and the client could also contact us between visits if they are concerned about an increase in symptoms or deterioration of functioning, so that we could do an assessment in between. In addition, we would also aim to streamline the pathway to care. So these individuals and their families are coming in to meet with a treatment team who are well aware of symptoms of early psychosis and are connected with treatment providers in the community. And so we can make an appropriate referral for them. We think about potential benefits for our community. So, an aim of this program is to reduce the duration of untreated psychosis in our community. And in terms of an educational benefit, this program provides a really unique opportunity for trainee clinicians, both in our doctoral program in clinical science and for psychiatry residents who want to be affiliated with the program. And in terms of potential benefits for the field, these types of studies have the potential to improve our understanding of risk and protective factors and long-term outcomes. So in terms of anticipated challenges, so we are thinking, just getting the word out about the program. We need to partner with community agencies and services for youth. Getting connected with schools, both middle schools, high schools, but also community colleges and universities. Getting connected with community mental health care providers, private practice therapists, physicians, and anyone else who may encounter young people who are at risk for psychosis along their pathway to care. Another anticipated challenge is access to mental health care in Iowa. So here we are working to build a referral network, and we've partnered with UIHC Psychiatry, identifying physicians who have an interest in early psychosis, so that we have a referral network. In terms of our future plans for the program, so as I mentioned a little while ago, community outreach and information campaigns have been demonstrated to have an impact on duration of untreated psychosis. So we do plan to engage in those types of campaigns. We are aggressively applying for funding to support both basic research and treatment studies. We want to identify biomarkers and novel treatment targets, also develop or adapt psychosocial interventions to enhance well-being and recovery. We hope to expand to other conditions. So for example, identifying young people at risk for bipolar disorder. And we hope ultimately to facilitate development of an early psychosis treatment program at UIowa or in Johnson County more broadly. So I want to thank everyone for their attention, and I'm happy to take any questions.
That was wonderful. Thank you, Amanda. There was a lot there to absorb. I think I will have to watch this again on our YouTube channel. But that's what's great is people can. Something early on in the treatment things, I wanted to ask you, about 15 years ago, I think is when I first started learning about anosognosia in many severely mentally ill people, and a lack of awareness for people who haven't heard that term, a lack of awareness that they are ill. So therefore they don't engage in treatment. Yeah. And that's also when I started reading Javier Amador's LEAP program. Yeah. Listen, empathize, agree, partner, which is that something that, I mean, what's your impression of that approach?
Yeah, it's a fantastic approach. It's a great book that's super accessible to families. And I know that NAMI sort of provides that book to families when they come in, the family to family program, right? The early psychosis program that I worked in at UCLA, we drew on that book very heavily. We always referred families to the local NAMI and recommended that they pick up that book.
Can you tell people in a nutshell what that is? I mean, I know what it is, but maybe other people don't, just like in a nutshell.
Yeah, so the idea is to try to facilitate engagement in mental health services for your loved one without sort of getting into this back and forth struggle with them, not getting into an argument about it. It's being able to establish boundaries for yourself as well, what you're willing to sort of what your limits are in terms of helping your loved one, but ways to communicate with them about your concerns, about their mental health, and how to access help. In addition to how to communicate with your loved one, I think there's a lot of great resources in the book to support the family member who's going through this struggle as well. And I know that the family to family groups provide great support there as well. So definitely we used the LEAP model at the early psychosis program in Los Angeles, and it's something we would hope to implement in early psychosis programs here.
Oh, I'm glad to hear that because it made an impression on me. So thank you.
Yeah. Let's see. I'm just looking through the chat. So Leslie is saying that there is also a program in Sioux City, Iowa, the Harmony program at Siouxland Mental Health Center. And Joanna, you had said it would be great if the state could get behind funding a statewide program, even if it started regionally. Can you tell me a little bit about the Colorado program?
Sure. The mental health center I was involved with we had started our own little program called TACT, which was a transitional age community treatment, which essentially was considered a first episode psychosis treatment for 15 to 29-year-olds. And then the state, who had funded us for that program, decided to make it larger, and they took it back, if you will, and called it Ascent. And now they have more community mental health centers in Colorado starting the program. And they hoped then to bring it statewide, but it is a state program and state funded. So, and it's, I learned a lot of the high level funding findings that you shared today when I was involved in that. But it was really great because it had peers involved. And I love to see peers get involved, young people who had really, they were able to sort of re-engage in their education and you know, do wonderful things. It's remarkable what can happen.
That sounds great. I know that the so I've had some communication with the folks at the first program up in Cedar Rapids, and it sounds like that may have been sort of from a state line of funding. I'm not entirely sure, but I would be interested to know if there is sort of availability of state funds to develop these programs throughout Iowa.
Well, then Leslie piped in, and you know, she's a very busy advocate at the Capitol, and she's not here. Leslie Carpenter.
Yeah,
she left. She said in the chat that but you know, she has been starting a conversation, it sounds like, with Representative Meyer, and I'm just thinking, you know, what could put together that might be, you know, something that we could take forward, and Leslie could have too, and the advocacy committee might have to, you know, make it really simple for these reps to understand. And some respond to the narratives, you know, the stories of individual families like Leslie. Some are more about cost savings, bottom line. And some are, you know, in community wellness. And so, you know, we could make sure we outline some of the benefits, which you'd be wonderful to, it'd be wonderful if you could help us with that.
Oh, for sure. Yeah, that sounds great. Yeah, I think so. Bengi and I have been trying to sort of, you know, get to know how the system of mental health services here in Iowa and availability of different types of grants and so on. And so it would be great for us to reconnect with Leslie to see, you know, if anything has changed since we met with her last summer.
Any other questions? That was great. Yeah, I'm glad you're located in the community. Don't have to wade through any strange campus buildings as a newcomer to Iowa. Pretty challenging.
Yeah. Well, thank you so much for inviting me to speak today. And Joanna, I'll connect you with Bengi after we get off the call so that you can talk to her about a lunch and learn. Thanks so much, everyone.
Much, Amanda.
Thank you.